In this particular section, we're going to discuss on the basics of sodium and water balance. So whatever I'm going to discuss in this particular video is going to form the quintessential important information for building up your blocks for future sodium disorders like hypo and hypernatremia. So usually, whenever I start these topics about water and sodium balance, I generally start with the term called osmolarity. You know what do you mean by osmolarity? The net osmolar force exerted by a particular fluid. So this is what we call it as an osmolarity or osmolality for that matters. Both are having subtle differences, but we are not going to learn physics or chemistry in this particular lecture. So just we'll take the term osmolarity. So what will be the formula for serum osmolality? Serum osmolality is defined as, definition wise, it's a net osmoles exerted by the particular blood column or particular plasma column, whatever fluid you are taking as a reference point. But what is the formula for the serum osmolality? It's a standard and a favorite formula, that is 2 multiplied by serum sodium plus glucose divided by 18 plus blood urea nitrogen by 2.8. So this is the standard formula. Suppose if you are using in millimoles per liter all these values, so what I'm trying to tell is if you use only milligrams per deciliter of glucose and urea, then this formula will be applicable, and this correction factors of 18 and 2.8 are important. Suppose if you are using in millimoles per liter, because a lot of European countries, even London, NHS uses this millimoles per liter as the standard. So if you're going to use that formula, then the same formula can be rewritten as 2 multiplied by sodium plus glucose plus blood urea nitrogen, which means what I'm trying to tell is you don't need the correction factor of divided by 18 and divided by 2.8 if you're going to use this millimoles per liter as the standard unit. All right. So this is the basic number one. This is the formula for serum osmolality. Is the serum osmolality same as that of the tonicity? So even though many people don't understand the difference between tonicity and osmolality, and again there are only very subtle changes, but this change is really important to understand. So what do you mean by an osmolality and what do you mean by a tonicity? So for example, you take a column of fluid. Let us assume this is a plasma or a blood for that matters. So you have a lot of osmoles. So different osmoles are there. Okay, so there are 3 osmoles in this. Let us assume one is the sodium, another is the glucose, and another is the blood urea nitrogen. That is the form of urea. So blood urea nitrogen means we are actually meaning nothing but the urea only. So what is the formula for blood urea nitrogen? Approximately blood urea nitrogen can be derived by the formula urea by 2, approximately. So this is the formula for blood urea nitrogen. But let us assume there are 3 molecules here, sodium, glucose, and probably the urea. So if I take this particular column, and what is the amount of osmolar substances that is present will give you my osmolarity. What is the amount of osmolar content in that particular column of blood is what we refer to as osmolarity. So, but tonicity is something different. Tonicity is the ability of this fluid column to move water in and out of this compartment. So this is what we refer to as tonicity, either in or out, whatever. So ability of the particular fluid column to move the water in and out of the compartment is what we refer to as the tonicity. So the total number of osmoles may not exactly predict the tonicity of a solution. Let us see how. For example, let us take this green is sodium and this red one is the glucose and this blue one is the urea. But if you ask about the sodium and the glucose, for time being understand these are extracellular compounds. Clear? This sodium and glucose, they are not going to cross the compartment predominantly. They are not going to go into the intracellular. Why I am telling is because when it goes into the intracellular compartment, glucose gets metabolized. Sodium, when it goes into the intracellular compartment, it goes actually, but it immediately comes back to through the activity of sodium potassium ATPase. So sodium is not going to stay inside the intracellular compartment, whereas glucose again is not going to stay because it's going to get metabolized immediately. So these two are extracellular substances only, they are not intracellular. But whereas this urea is something called a permeant solute. What do you mean by a permeant solute? This urea can be present both in the intracellular compartment as well as extracellular compartment, which means they are in equilibrium with the ECF and the ICF. So they are solutes only, but they are permeant solutes. Whereas the sodium and glucose, especially the sodium, is typical example of an impermeant solute. Even glucose, relatively impermeant, but this blood urea nitrogen, this urea is often referred to as something called a permeant solute. Permeant solute. Since they are permeant and they are in equilibrium with the ICF and the ECF, you can see here they are in equilibrium with the ICF and the ECF, which means there is no net effective osmolar force or there is no net effective tonicity that is exerted by urea in natural circumstances. So which means I can rewrite something called as effective osmolality. So this is what I am going to mean by the term tonicity of solution. So effective osmolality is something different. It is contributed only by sodium and the glucose, but not by the urea. So urea can be eliminated from the effective osmolarity because even though it's a solute, and if you take a column of blood and you see whether that has an osmol or not, yes, that osmolality of that particular blood column will include urea obviously, but whether they exert the tonic force or tonicity is something different. They don't do that. So that's why we eliminate the term urea whenever it comes to effective osmolality or tonicity. Point number one. Next, there are certain exceptional scenarios, especially in the brain. So because when I'm going to discuss in nephrology about certain circumstances like dialysis disequilibrium syndrome, there I'll be telling rapid reduction of the urea is going to be the prominent reason for developing that dialysis disequilibrium syndrome. That time you can ask me, sir, you told urea is an ineffective osmol and urea is a permeant solute, then how rapid reduction in the urea will affect the osmolar forces and causing cerebral edema. But you have to understand, there is something called a blood-brain barrier, and in the brain, urea behaves a little differently. Urea, water and all these things behave a little differently in the brain compared to that of the other areas. So leave the brain as of now. Other areas, urea is an permeant solute and it's an ineffective osmol, and it will not contribute to the net tonicity or effective osmolality of the particular solution. Fine. So this is the first thing I want to understand. So why we are worried about the serum osmolality in the first place? Why actually we worry about the serum osmolality? So because the serum osmolality is the one that is a sample of how much you have the ECF osmolality, because ECF is present in the, one of the components of ECF is the plasma, that is the serum. So whenever you take the plasma osmolality or the serum osmolality, it is a sample of how much your ECF osmolality is present. So this ECF osmolality is really important because that is the one that's going to determine the fluid shift between the other compartment, that is the ICF. So let us go back to the basics and see what are the how many compartments of fluids are there in the body, which means water compartments. So you know this term that is called a total body water. Usually according to your standard physiology textbooks, it is 60% of the body weight. So here it is water, here it is weight. So don't get confused by two W's I am writing here. Both are different. So 60% of the body weight. But for all practical reasons, clinicians like us generally prefer to use that is 50% of the body weight. So you have the total body water and you know how it's going to get distributed. 2/3 of it and 1/3 of it. 2/3 of it will be in the intracellular compartment, ICF water, and 1/3 is the ECF water. That is extracellular fluid. So in the ECF, again this ECF is going to be divided into 4/5. That is 80% of the ECF will be the interstitial fluid compartment, and 1/5, that is 20% of the ECF, will be locked up in the plasma compartment. Fine. Now, if I want to write in body weight terms, 2/3 of 60% will be almost like 40% of the body weight is locked up in the ICF water, and 20% of the body weight is locked up in the ECF water. Similarly, 80% of this 20%, that is 16% of body weight is locked up in the interstitial fluid water, and 20% of this 20% means it comes to 4% of the body weight will be locked in the plasma water. So this is the final say. Now I can tell ECF osmolarity. The osmolarity of the ECF is the one that's going to determine, or ICF osmolarity for that matters, whatever may be the issue, but the fluid shift between the ECF and the ICF is completely determined by the osmolar forces, either by the ICF osmolality or by the ECF osmolality. Both will be in equilibrium usually, but if some changes happen in the osmolar forces, there will be a net fluid shift. So let us assume, first of all, osmolarity of the ECF increases. what will happen? Suppose if ECF osmolality increases, you know that water is always going to move from a region of lower osmolality to a region of higher osmolality, which means from a region of lower solute concentration to a region of higher solute concentration, simple chemistry. So now the water is going to move towards the ECF, which means the ICF is going to shrink. Whenever ECF osmolality is increasing, water movement will be from ICF to ECF and the ICF will shrink. Similarly, whenever the osmolality of the ECF decreases, means your fluid shift is going to happen from a region of lower osmolality to a region of higher osmolality, which means the water shift will happen towards the ICF and the ICF is going to swell in this situation. The cell is going to swell, the ICF is going to expand. Fine. So why serum osmolality is important? Because this ECF osmolality means I can tell is the serum osmolality, which means like plasma is nothing but the serum, which means plasma is nothing but a component of the ECF, which means I can tell serum osmolality and I can approximately tell what is the ECF osmolality, and that will be the ECF osmolality as well. So serum osmolality, who is going to determine the serum osmolality? That's why we are talking about all these things right now. Serum osmolality is predominantly determined by the serum sodium or ECF sodium. Again, the serum sodium is going to be the sample of the ECF sodium. Sodium is the one that's going to predict the osmolar forces of the ECF. How? Let us see. What is the normal serum osmolality? If somebody asks you what is the normal serum osmolality, I can easily tell the answer will be 280 to 295 milliosmoles per kilogram. 280 to 295 milliosmoles per kilogram. Which means I can also tell the fact that certain nephrology textbooks will give the range of 275 to 295, but certain medical textbooks, including CMDT, will give 285 to 295, but whatever you want, you can follow. But I take the value of 280 to 295 milliosmoles per kilogram. Fine. So now, you know very well, the formula tells serum osmolality is 2 times the serum sodium, right? Which means what is the normal sodium? Normal sodium is 136 to 144 milliequivalents per liter. And this is not going to change. Even in US or UK, wherever you go, this is the standard value. 135 to 145 is also right, but I believe in 136 to 144 value. So average, I can take 140. Let us take, for example, 140. And serum osmolality is 2 times the serum sodium as per the formula. Plus, leave the glucose as of now. So what do you mean by 2 times the 140? When you multiply 2 into 140, you are going to get 280. That is almost equivalent to the normal serum osmolality under physiological conditions. Which means the entire of the serum osmolality under physiological states, almost entire, is contributed by the serum sodium only. That is the reason in physiological as well as majority of the pathological states, the one thing that is going to change this serum osmolality is the serum sodium. So what is the sodium? That is the biggest predictor of how much is going to be the serum osmolality. Okay, it's really, really important to understand. So serum sodium is going to be the biggest game changer in the osmolar forces of the ECF and as well as the serum. Fine, that's why I told you very clearly that sodium is the one that's going to be a biggest game changer for ECF as well as the serum osmolality, which means the entire osmolar forces and the entire fluid shift that is happening between ECF and ICF itself is based on the sodium values only. Because every small changes in the sodium is going to affect the osmolar forces by a factor of 2. Clear? So it means it's really important to understand that particular point. Next thing, glucose, you might ask me whether they are going to affect the osmolar forces. Yes, but at only very high significant concentrations of glucose, they are going to affect the osmolar forces. But at physiological ranges, they don't contribute that much to osmolality. For example, let us take a glucose of 108, which is normal, divided by 18 is going to be 6, which means glucose, it's contributing only up to 6 points in the 280 or 290. 280 is contributed by the sodium and only 6 or 7 at physiological stage is contributed by the glucose, which means it's not that much contributor of serum osmolality under physiological states. At the same time, I'd like to tell one important fact that glucose in the presence of insulin is not a problem at all. Because glucose, whenever there is an insulin, insulin activates through the IRS receptors, IRS pathway, insulin receptor substrate pathway, and the RTK receptor tyrosine kinase pathway. They are going to cause a lot of intracellular changes, and they increase the GLUT4 transporters on the surface of, for example, a skeletal muscle. And this is going to increase the glucose uptake into the cell, glucose uptake by the cell, and they will increase the glucose utilization of the cell also. Which means this glucose disappears actually from the ECF, even if the glucose level rises. So glucose is maintained in physiological ranges by insulin. So glucose in the presence of insulin is not a problem. But glucose in the absence of insulin is where the problem is. Which means there will be no uptake, which means the glucose level starts rising dramatically, and at very high levels, for say maybe 600 or 800, they are going to exert their osmolar forces, and they're going to increase the serum osmolality, and they will result in fluid shifts. And that fluid shifts will result in a lot of complications. Let us see what will be the complications. And that is also one reason why there are two disorders, DK and hyperosmolar hyperglycemic syndrome, that's called HHS, previously called as HONC, hyperosmolar non-ketotic coma. The other term is, other disease that is related to HHS is DK. Let us see the difference in the pancreas chapter. But this is really important to understand. Only at very high levels, glucose is going to cause fluid shifts. At physiological levels, glucose will not have any impact. The sodium is the major game changer, as I told you already. Sodium, sodium, and sodium. Why we are worrying about this osmolar forces, and what is the importance of this osmolar force, and who is going to suffer the maximum brunt by changing this osmolar forces? See, I told you, whenever you change the osmolar forces, the ECF either shrinks or ICF either shrinks or ICF either swells, which means the cell shrinks or the cell swells. So let us assume the cell is going to swell. Who is going to bear the brunt when the cell is going to swell? When the cell swells, one organ is going to bear the maximum brunt, that is the brain. And when the cell shrinks, again one organ is going to bear the maximum brunt, that is the brain again. So why brain is bearing the maximum damage and maximum brunt? That is because of one important physiological doctrine called as Monro-Kelly doctrine. What Monro-Kelly doctrine tells? In very simple terms, brain is inexpansible, or any structure inside the cranial cavity is inexpansible, and one structure, if it wants to expand, it can expand only at the compromise of the other structure. Only at the expense of other structure, then only it can expand. So in mathematical terms, it clearly tells volume of the brain plus volume of CSF plus volume of blood in the cranial cavity must be constant. For example, if you add some space occupying lesion inside the brain, like hemorrhage or probably a tumor, obviously this is going to occupy extra volume. By Monro-Kelly doctrine, this cannot change and this must be constant. So how can they occupy this extra volume? Only by compressing the brain. You have to reduce the volume of all the other compartments to a considerable range, then only they can adapt to this extra space occupying lesion. That is the reason why this brain volume cannot reduce, but the brain inside the cranium will try to escape through the orifices, through the foramens, and that's why you get the herniation. Same problem with cerebral edema as well. Whenever your ICP rises, because of cerebral edema, there is increased risk of herniation and death. And that is exactly the problem with sodium changes, because they are going to change the osmolar forces. The brain swells, but there is no place for the brain to expand. It herniates and the patient dies. So there is high risk of herniation, and especially in selected group of patients who are undergoing this sodium changes. So that is where the famous proverb is. For example, if you take the sodium changes, even a sodium of normal is 136, 144, even a sodium of 80, 85 we have seen, they don't cause any problems in the heart, which means sodium changes are not going to affect the heart. But who's going to affect the heart? Potassium changes. That's why the famous proverb is there, sodium hammers your brain, potassium stabs your heart. Clear? So they kill you by, causing herniation, sodium changes. But potassium changes kill you by causing arrhythmias, very commonly. Okay. Now, what are the effects of this osmolar force? I told you between ICF and ECF, the most important reason for the fluid shift between ICF and ECF is the osmolar forces, which means what osmolality? The ECF osmolality, that is really important, and which is indirectly I can write as the serum osmolality, which means all these things I can replace it by telling serum sodium. That is going to be the major ion that is going to exert the osmolar force and causing the fluid shift between ECF and the ICF. So let us assume now the serum sodium is increasing. When the serum sodium increases, the fluid is going to shift towards the ECF because ECF is going to have higher osmolality. Similarly, whenever the serum sodium is low, the ECF osmolality and ECF sodium will be low, which means the fluid is going to shift towards ICF. Clear? So which means in this condition, ICF will swell. In the red condition which I told, ECF volume will increase, but ICF will shrink. So let us take a perspective of what is happening here. First, let us take this is the ECF for understanding, and this is the ICF. Whenever you have low serum sodium, that is hyponatremia, obviously this is going to result in fluid movement into the ECF. Because of low osmolar force in the ECF, water moves from a region of lower osmolality to a region of higher osmolality. Remember, even though the ICF osmolarity is normal, ICF has a normal osmolality when you take the reference ranges. But I cannot call it as a normal osmolality because you have to always see in relativistic terms. What is the cell living in its milieu? It is exterior. So that's what we have to see. So according to the milieu, that is outside, ECF is having low osmolality. Relatively speaking, the ICF is having more osmolar forces compared to that of the ECF. So that is the reason why this relativistic problem is the reason why the water actually shifts from ECF to ICF. So that is the reason why ICF is going to swell. I mean the cell is going to swell. The cell swells because of excessive water, and this is going to get translated as cerebral edema. And if all the cells swell in the brain, that is definitely going to raise the ICP because of cerebral edema, and patient will go for altered mental status, then weakness, then they can even go for coma, seizures. A lot of problems are there. So they can go for all these complications, headache, nausea and vomiting, a lot of neurological complications. That is because of cerebral edema. Fine. Now, cell, is a living structure. It's not an inanimate object like this chair or a table or a mic. Cell is going to be a living component and a living structure. So they are going to adapt. See, that is the basic essence of biology. Ability of a particular cell, why you call a cell? Because ability of a particular thing to adapt to its environment. So it responds to its environment. So that is how a living thing is. That's what you differentiate from a living and a non-living thing. A non-living thing doesn't usually adapt to its external environment. But a living thing adapts to its external environment, and it is going to be in milieu with the external environment. So which means here the cell understands by a lot of its mechanisms. Whether it has a consciousness or not is a different topic of debate, but it is having that ability to adapt to the external environment. Here it understands one important thing, that why there is a fluid shift. Here you have to understand why the fluid shift is happening. This fluid shift is happening because the cell is having relatively higher osmolality compared to that of the ECF. That is why. So cell understands this thing, and the cell will start losing its osmoles. The cells will start losing osmoles. What are the osmoles that is present inside the cell? One of the major osmole inside the cell is potassium. Many people ignore potassium as an osmole, and please think that potassium is as good as an osmole as that of sodium. So which means potassium is something underestimated often because it's present always inside the cell, not outside the cell. The sodium and chloride, salt. Sodium, chloride are extracellular cations. Clear? Extracellular cations and anions. These are extracellular ions. Potassium and phosphate are intracellular ions. We know that. But potassium is a very good osmole that is present inside the cell. So what I'm trying to tell is they lose potassium, number one. Number two, they're going to lose a lot of organic osmoles. Potassium is an inorganic osmole. And you have a lot of organic osmoles in the form of glutamate, glutamine, and probably myoinositol. A lot of other osmolytes are there, myoinositol. So they start losing this osmoles, which means when they start losing this osmoles to the outside, now they can reduce the osmolality and they can reach the equilibrium with the ECF, and once again they will bring back to the original size. The cell will come back to the original size. So what is going to happen now is exactly this. So here the osmolarity is actually relatively low, and the cell is also going to reduce its osmolality, which means it's going to form an equilibrium by losing the osmoles. Now this is a cell that has lost osmoles. Because the cell has lost osmoles, it has reduced the osmolarity that is equal to that of the ECF. So this is the ECF and this is the ICF. And now they become normal size, back to the original size. Not exactly normal, but at least they will try to shrink back to their attempt to get back to their original size, because that's what we call it as adaptation. Okay. Now what's really happening now is, so this is not a problem. So this is what is happening in adaptation. This is what we call it as cellular adaptation for hypoosmolar problems. Okay, this has happened. This usually takes place within 4 to 6 hours. Within 4 to 6 hours, the adaptation starts, and usually adaptation will reach its maximum by 48 to 72 hours. By 48 to 72 hours, the adaptation will be at maximum. Cell, even though may not reach the completely normal size, but it tries to adapt as much as possible, that it peaks at 48 to 72 hours. That's why there is definition of acute hyponatremia, chronic hyponatremia. If we take within 24 hours, it's called acute hyponatremia, and after 48 hours, we call it as chronic hyponatremia, because that is to define these adaptive changes that is happening inside the cell. So now the cell has, let us assume it has fully adapted, it almost the same size by reducing the osmolarity. So now let us assume a doctor. I am seeing a doctor's eyes here. Doctor is seeing this change in the osmolality. Now he's seeing the ECF, because he cannot see what is happening in the ICF. He's seeing the ECF and he's seeing that the osmolarity is low, which means the serum sodium is low and the serum osmolality is low. What he thinks, like osmolarity is very low and the serum sodium is very low, and I have to improve the serum sodium and I have to improve the serum osmolality immediately, because he thinks that that is a major problem over there. So he tries to correct the serum sodium and serum osmolality very fast. So now what he's trying to do is, now he's trying to normalize. Remember, he's only trying to normalize. Nobody is planning to kill the patient by giving more osmolar forces. He's just trying to give sodium to the patient, and he's trying to normalize the serum osmolality as far as he knows. He knows that 280 to 295 is the normal osmolality, and 135 to 145 is going to be the normal sodium, and he's attempting to reach that from a lower value. So he has reached that. Let us assume he is successful in reaching that. But he didn't consider the fact that this cell is still having lower osmolality and it has adapted already. So he has to consider this fact. Why? Because you have to give some time for the cell to come back to the normal osmolality, at least from the lower range. So again, adaptation will take at least what? 4 to 6 hours, at least for 24 hours, and it will adapt maximally only at 48 hours, which means it needs time. You cannot change like this very rapidly. So since you have changed very rapidly within a span of hours, within a span of like 3 hours or 6 hours or 10 hours, so what happens is, now the cell is still at a lower osmolality, and even though the serum osmolality and serum sodium is just became a normal value by now, so what you are going to end up is again a fluid shift, because the cell has not yet adapted to your rapid correction. So what you have done is rapid correction of serum osmolality and serum sodium, and the cell is not yet adapted to this change, to this new change. Adapted to new change in the osmolality. So now, if you see, this normal osmolality is relatively higher compared to the lower osmolality that is present in the inside the cell, ICF. So now water always moves from a region of lower osmolality to a region of higher osmolality, which means the ICF is going to shrink faster and faster the more faster you correct, and this shrinking of the ICF itself, the shrinking of the cell itself will result in complications like ODS, that is called an osmotic demyelination syndrome, and second one is called ICH, that is intracerebral hemorrhage. Why intracerebral hemorrhage? Very simple reason. suddenly the fluid movement into this small vessels over here. This small vessels, because of the sudden movement of water from the cellular compartment to these vessels, they will expand and they will pop out and they result in intracerebral hemorrhage, ICH sometimes. So you have to be very, very careful. These are the complications of rapidly correcting hypoosmolar changes. So I can put a table. Now you have hyponatremia and you have a hypernatremia. What will happen if you do an acute hyponatremia? Remember, chronic hyponatremias are less dangerous compared to that of acute hyponatremias because you are giving time for the cell to adapt. So it is less dangerous. But acute, you're not giving the cell time to adapt. So that's why it is a problematic thing. So acute hyponatremias, obviously you know what is the problem. They are going to result in cerebral edema. That is the main problem. We saw that already. Similarly, rapid correction of acute hyponatremia is going to result in different set of problems like osmotic demyelination syndrome and intracerebral hemorrhage. This osmotic demyelination syndrome previously is called as central pontine myelolysis. Now the term is no longer used. We use the term called ODS only, but let us see why later on when I speak in next video about the hyponatremia and hypernatremia. So what will happen in acute hypernatremia? Acute hypernatremia, usually you end up only in altered mental status. You won't end up in much problem. You can result in ICH and you can result theoretically in ODS. This is only theoretically. You can result in ODS because rapidly you are increasing the serum osmolality, which means again acute hypernatremia is a risk factor for getting ODS. But this getting ODS through acute hypernatremia is very, very rare. You can see again because of the osmolar forces only. And rapid correction of hypernatremia will result in cerebral edema. Why? Whenever the patient is having hypernatremia and you rapidly lower the serum osmolality, cell will adapt. Obviously during hypernatremia, the cell also would have adapted by raising the serum osmolality, ICF osmolality. When you rapidly lower the serum osmolality in a patient who is having hypernatremia, again, this rapid lowering of serum osmolality, relatively this is having lower osmolality of ECF and the fluid shift will happen to the ICF and the ICF will swell and you will get cerebral edema. So what I am trying to tell is acute hyponatremia and rapid correction of hypernatremia will result in cerebral edema, and rapid correction of hyponatremia and acute hypernatremia may result in ICH and osmotic demyelination syndrome theoretically, but osmotic demyelination syndrome is always almost a complication of rapid correction of hyponatremia, which means this ODS is almost always an iatrogenic condition. A patient who's coming with a simple sodium problem, going out with a wheelchair because of ODS, because of pontine myelolysis, is something like a grave mistake. It's a negligence. You should not do that and you should try to avoid that. You are permanently either killing the patient or disabling the patient. So this is not acceptable at all. It's completely, as of now, it's an iatrogenic problem. ODS is equal to iatrogenic, rapid correction of hyponatremia. Clear? So very, very, very important concept to understand. So this hyponatremia and hypernatremia. So why this is going to kill the patient? Fine. Remember, both acute and hyponatremia is also a problem and rapid correction of hyponatremia is also a problem. Similarly, both acute hypernatremia is also a problem. At the same time, rapid correction of hypernatremia is also a problem. So be very careful. So these are some of the important things that you have to understand in the first place. But we discussed one important thing, that the fluid shift between ECF and ICF is actually mediated by osmolar forces. But who's going to mediate the fluid shift between this interstitial fluid and the plasma? This fluid shift between the interstitial fluid and the plasma, these are two compartments that are located within the ECF, you know that. And the fluid shift between these two compartments is mediated by your Darling forces, which are nothing but the Starling forces. These Starling forces are the one that are going to determine the fluid shift between the interstitial fluid and the plasma. Which means, if you take this is the plasma compartment, and this is the interstitial fluid compartment where the cells are located. This is where the milieu is, where the cells are located in interstitial fluid. So there are two forces that are acting. One is the force that is trying to push the water into the interstitial fluid, that is capillary hydrostatic pressure. This is the interstitial fluid and this is the plasma. And the capillary hydrostatic pressure is trying to push the fluid into the water into the interstitial fluid compartment. Whereas your colloidal oncotic pressure, these are the two important Starling forces. The colloidal oncotic pressure is the one that is trying to take this fluid back into the plasma from the interstitial fluid compartment. So always there is a balance between these two forces. What I will tell is, again, in physiology, you would have studied arterial end and venous end, where arterial end you will have hydrostatic pressure more than the oncotic pressure, whereas in the venous end, hydrostatic pressure will decrease, oncotic pressure will increase. So in the arterial end, your filtration will happen, and in the venous end, your reabsorption will happen, so that it will all be in a balance. Suppose if capillary hydrostatic pressure is abnormally increasing, you will result in interstitial fluid volume to increase, and you might result in edema. So what are the conditions where capillary hydrostatic pressure can increase? Remember, capillary hydrostatic pressure can increase by various reasons. The most important condition is the sodium overload. The body sodium overload, or I can write as increased total body sodium. We are moving on to the next concept slowly. Without knowing itself, we are moving on. I'll tell you. I'll explain you. So there's going to be sodium overload. Okay, that is going to be the most important reason for the interstitial fluid volume increase, that is the edema. This sodium overload can be due to a variety of reasons. One, the most important reason is the renal failure. That is one of the very, very important reasons. And after the renal failure, you get RAS activated states. So you can ask me, sir, is renal failure not a RAS activated state? No, it's not a typical example of a RAS activated state. Renal failure, you have sodium overload because of the low GFR, that's all. That's due to hypofiltration, low filtration, low GFR, that's all, dot. Whereas this RAS activated states is completely different. Even though renal failure, there will be some cases there will be RAS activation, but not all the cases. Most of the renal failure, 75 to 80% is due to low GFR and volume dependency only. Whereas there are certain typical RAS activated states. Even in sleep, if they ask you, you should get up and tell there are three conditions, that is CHF, congestive heart failure, cirrhosis, and nephrotic syndrome. These are the three characteristic RAS activated states where the edema is typically due to sodium overload only due to sodium overload. So all these conditions, edema is due to sodium overload. So why they are RAS activated in the first place? Because in all these conditions, there will be low effective arterial blood volume. So now there's a new terminology, effective arterial blood volume. What do you mean by low effective arterial blood volume? The amount of, the patient might be edematous and they have volume overload, but the amount of volume that is circulating in the vascular compartment is actually less. So because they have low effective arterial blood volume, they are going to activate the renin through the juxtaglomerular apparatus, because these sends the intravascular volume in the kidney. And this renin will produce angiotensin 2, and this angiotensin 2 will produce aldosterone, and this aldosterone is going to produce sodium reabsorption, increased sodium reabsorption and sodium overload. So you can see this system is called renin angiotensin aldosterone system, called as RAS. That's why I told you RAS activation here. Fine, all right. So CHF, very, very easy to understand. The reason why you have low effective arterial blood volume is due to low perfusion and low pumping of the heart. Because cardiac output is low, the perfusion will be low and the pumping will be low, so the effective arterial blood volume will be low only. Similarly, in cirrhosis, there will be splanchnic vasodilation. We have been talking about this in the previous video, splanchnic vasodilation, which is very important in cirrhosis. We'll discuss the pathophysiology later on in some time. What do you mean by splanchnic vasodilation and why this splanchnic vasodilation is important? So because of splanchnic vasodilation, reduced resistance in the splanchnic circulation. Splanchnic means your abdominal vasculature, that is mesenteric vasculature. Because your splanchnic vasculature is dilated and lot of blood starts pooling, because you have low resistance there, lot of blood starts pooling into the splanchnic vasculature, and because of that, other areas of the vascular compartment will have low blood volume. Very simple. That's due to pooling of the blood in the splanchnic circulation, causing low effective arterial blood volume, and because of that, you will be activating RAS. That's due to splanchnic vasodilation only. Now, what about nephrotic syndrome? This is something very crucial to understand. Nephrotic syndrome, why you have low effective arterial blood volume and why you get RAS activation nephrotic syndrome. It's quite simple. Again, you have two theories. One is called an overfill theory, and second one we have underfill hypothesis. Overfill hypothesis is fairly straightforward. You have a glomerulus and a tubule, and in nephrotic syndrome, you know, these are the afferent and efferent artery. Nephrotic syndrome, we all know that there is going to be leakage of the proteins. These proteins that are leaking in the tubule and coming in the urine, while coming into the tubules, they have some protease activity, and that is going to cleave certain subunits of a channel called epithelial sodium channel. You know, where is the epithelial sodium channel? In the collecting duct, in the principal cell. Principal cell is the principal site of aldosterone action. We'll discuss in detail later on. So these are nothing but ENaC channels. ENaC channels are the ones that cause the sodium reabsorption through aldosterone action. Aldosterone acts on the ENaC channels. Or increase the functional activity and number of ENaC channels. That is how aldosterone increases the sodium reabsorption. So these proteins that are leaking through the nephron, leaking through the tubule, is going to activate this ENaC channel, which means they are going to increase the sodium reabsorption, similar to that of how RAS activation is. This is what we refer to as overfill hypothesis, that proteinuria itself is the responsible event for sodium reabsorption. What do you mean by underfill hypothesis? Underfill hypothesis says that because of the hypoproteinemia, that's going to lower the colloidal oncotic pressure. Low colloidal oncotic pressure. Here the capillary hydrostatic pressure will be okay. Capillary hydrostatic pressure tries to push the fluid out of the plasma into the interstitial fluid compartment, whereas this colloidal oncotic pressure tries to push the fluid back into the plasma compartment. But here the colloidal oncotic pressure is not properly working, so which means there will be fluid accumulation in the interstitial fluid compartment. So it tells you, because the fluid is accumulating in the interstitial fluid compartment, there will be low intravascular volume, and that is the reason for low effective arterial blood volume, because fluid stays in the extracellular fluid, in the interstitial fluid itself. It doesn't come back to the plasma compartment. So there will be low effective arterial blood volume, low intravascular volume, because of the renin is activated, angiotensin, aldosterone, and sodium overload. So what is the biggest evidence that to tell all these conditions are due to excessive sodium reabsorption? So all these conditions have excessive sodium reabsorption due to RAS activation. Now what is the evidence for that? Evidence is all these three conditions uniformly will have low urinary sodium, but whereas renal failure will have high urinary sodium, which clearly tells the problem in renal failure is not this sodium reabsorption, because they have high urinary sodium. The problem in renal failure is low GFR. Similarly, in these conditions, RAS activated states, there will be low urinary sodium, which means the high sodium reabsorption is the main reason why you get sodium overload and edema in these patients. Clear? So this is the idea. Now, what happens if you reduce the colloidal oncotic pressure? If you reduce the colloidal oncotic pressure, a lot of conditions can reduce colloidal oncotic pressure, typically conditions that produce hypoproteinemia. Any condition. The best examples are cirrhosis and nephrotic syndrome. Even though that is the reason why you reduce the colloidal oncotic pressure, but that's the reason why it is postulated, one of the reasons postulated to cause edema and fluid overload. But most importantly, the reason is sodium overload due to RAS activation, the main reason for CHF cirrhosis and nephrotic syndrome to have edema. Clear? So you have to understand the fact, even in dreams, if someone asks, you have to tell these three conditions. These are RAS activated states, classic RAS activated states. They have low urinary sodium. Clear? All these things are very, very crucially important to understand. So now we have discussed about the Starling forces also. Clear? So which means what is going to cause volume overload state? The total body sodium. So that is how we are moving on to the next concept of something called total body sodium. The concept of total body sodium, and what do you mean by serum sodium, and what do you mean by total body water. These three things, these three triangular things, you have to understand. What do you mean by all these three things? Remember, first of all, I would like to tell that the total body sodium is the one that determines the volume status in the body. Volume status in the body is actually determined by the total body sodium only. How is it possible? How they determine the volume status? So again, let us go back to our original description, that is total body water is divided into ICF and ECF. ECF majority is in the interstitial fluid compartment and little bit is in the plasma. Let us go back to our understanding. And ICF is also going to have another compartment called transcellular fluids, which includes the pleural fluid, peritoneal fluid, pericardial fluid, CSF. All these things will come under this transcellular fluids, serosal fluids. Leave the CSF, that is after the blood-brain barrier, and we're not going to consider about that. So pericardial fluid, pleural fluid, and peritoneal fluid, very, very important fluids that are not surrounded by any barrier. At the same time, they are very, very important transcellular fluids. Now, I am increasing the total body sodium. So what do you mean by increasing the total body sodium? So which means I am actually increasing the ECF sodium only. Increase ECF sodium. That's what it indirectly means. Why can't it enter the ICF? What is the reason? Very simple reason. So you might ask me, sir, you are telling you are increasing the sodium. Let us assume this is the ECF. Let us assume this is the ICF. And you are actually increasing the sodium, the total body sodium in the whole body, which means it should increase in the ECF also, it should increase in the ICF also. Yes, absolutely your logic is correct. It should enter both ECF and ICF. But understand, ICF cannot take up the sodium and it has to immediately push the sodium out because of the continuous activity of a pump called sodium potassium ATPase, which means over time this sodium is going to disappear and it's going to come out of the ICF and it will stay in the ECF only. That is the reason why ECF is an extracellular, sodium is an extracellular cation. That is due to continuous activity of the sodium potassium ATPase, which works 24/7. It works for you. It is the one bloody pump that is going to use 70% of your daily ATP production. This sodium potassium ATPase is vital for your daily or even momentary survival. If it doesn't work, you will die. Because sodium has to be maintained outside because of a lot of reasons. For example, when sodium comes inside, it's going to exert osmolar force, the cell will swell and you are going to die by cell swelling and rupture. Point number one. Second, you have action potentials. And this gradient between sodium and potassium, outside sodium and inside potassium, has to be maintained. So one action potential comes, sodium moves in, potassium goes out. Then what about the next action potential? Where is the sodium to come inside? All have already come inside the cell, isn't it? So this has to go out and the sodium gradient has to be maintained. That is in the ECF for continuous action potential to happen again and again. So for example, when you do some mess, who's going to clean the mess? The cleaning of the mess is done by the sodium potassium ATPase. Works 24/7. It is the one thing that keeps you alive. And this is the one that maintains the gradient, that is sodium should be outside and potassium should be inside. So sodium is not going to stay inside the cell unless and until there is some damage to the sodium potassium ATPase, or if you have ischemia, especially. The ischemia reduces the ATP. Sodium potassium ATPase is totally dependent on ATP. So low ATP will result in poor activity of sodium potassium ATPase, and that time only you will get the cell swelling, which is the first sign of cell injury. Clear? So fine. So sodium should be outside, that's all. Sodium is an extracellular cation. So it will be in the ECF only. So increasing ECF sodium means I am actually increasing the ECF osmolality. If I increase the ECF osmolality, there are a lot of things that is happening. I am going to cause fluid shift from ICF to ECF. At the same time, this increasing ECF osmolality will activate the hypothalamus. Not directly, through the osmoreceptors in the circumventricular organs, they are going to activate the hypothalamus, and hypothalamus will cause excessive thirst, which means you are going to increase the water intake. At the same time, they are going to increase the ADH release. You know what ADH is going to do? Antidiuresis, reabsorb more water. So they are going to cause more water reabsorption. By somehow you are going to increase the water, and which means ICF is now going to be loaded with water. A lot of water is going to enter the ECF from the ICF as well as from the drinking as well as from ADH mechanism. So this excess water, obviously ECF is not a wholesome compartment. It's going to again compartmentalize into two different compartments, that is interstitial fluid and the plasma. So interstitial fluid volume is going to increase, interstitial fluid is going to swell, and plasma is also going to swell. If interstitial fluid volume expands, what do you call that as? Volume overload state. That is what we call it as a volume overload state. So because interstitial fluid expands, it will result in edema. And again, transcellular fluid is a component of interstitial fluid, and again they will expand, resulting in pleural effusion and ascites. So this edema, pleural effusion, ascites, all these things are examples of volume overload state. Similarly, if the plasma compartment expands, you are going to result in hypervolemic state. Hypervolemic state. What is hypervolemic state? There is only subtle difference between hypervolemia and volume overload. Hypervolemia means the vascular compartment is expanding. Obviously, it will result in high JVP, jugular venous pressure. In exceptionally severe cases, you might even result in hypertension also. Okay, this is what we call hypervolemic state. The exact reverse happens if there's going to be reduction in the total body sodium. So whenever the total body sodium reduces, you're going to result in exact reverse. So what do you mean by exact reverse? When the total body sodium reduces, your interstitial fluid volume is going to reduce, and the plasma volume is also reduced because the ECF volume is going to reduce as well. Opposite. So reduction in the interstitial fluid volume, we call it as volume depleted state, or even you can call it as a dehydrated state. What do you mean by volume depletion? When interstitial fluid volume decreases, it will result in sunken eyes, loss of skin turgor, and dry mucous membranes and dry skin, all these things you can get because of low interstitial fluid. Because interstitial fluid is the one that keeps you shiny. You will get dry. Then, if the plasma volume shrinks, you will result in hypovolemic state. What do you mean by hypovolemic state? The blood is going to shrink, resulting in low JVP, postural hypotension, or even in exceptionally severe cases, you might result in low BP and frank hypotension and shock also. These are what we refer to as hypovolemic states. Very, very important, which means what I'm trying to tell is the total body sodium is the one that is actually important for determining the volume status in the body. Very, very important event. Now we can understand, isn't it? So where I have written, so this total body sodium is the one that is going to actually determine the volume status in your body. So what about the serum sodium? You have to understand that serum sodium is never equal to the total body sodium. So whenever serum sodium increases, it doesn't mean total body sodium is increased. The total body sodium even may have decreased. So you have absolutely no relationship between serum sodium and the total body sodium. So what is the relation? Let us strike this off, and I can tell serum sodium is an approximation of total body sodium and total body water. So it's a very simple thing to derive. You have a lot of complicated formulas and math behind this. I'm not complicating it. I'm just giving and making you understand in a very simple way. When you take a concentration of a solution, it is determined by the amount of the solute divided by the amount of the solvent. That is volume of the solvent or the amount of the solvent. Take a whiskey, take a water. Whiskey is the solute, water is the solvent. So concentration of the whiskey depends on how much water you add. That's all. That is the formula. Concentration equal to amount of the solute by volume of the solvent. So I can write total body sodium is the solute here. Water is the solvent here. That is the volume you are mixing. And serum sodium is the concentration of the total body sodium. That is the whiskey there. Alcohol. Very simple derivation. So serum sodium is going to be determined by the total body sodium to the total body water ratio. That's all. That is going to predict the serum sodium in the first place. Then, what all can you derive out of this formula? So first let me take, you have something called an isotonic disorder. What do you mean by an isotonic disorder? So let us write the formula again. Serum sodium is actually a approximation of total body sodium and total body water. So now I can tell a condition where total body sodium is also decreasing and total body water is also decreasing. When the total body sodium is also decreasing and total body water is also decreasing, you can see that the numerator and the denominator both are going down proportionately, which means the serum sodium will be maintained in the normal range. So what I am actually seeing, because the total body sodium is decreasing, I can tell patient will be definitely hypovolemic. But since both water and sodium are decreasing proportionally, water and total body sodium are decreasing proportionally, the serum sodium will be maintained in the normal range. This is what we refer to as hypovolemic normonatremia. The classic example of hypovolemic normonatremia is loss of isotonic solution or isotonic fluid from the body. If you want to lose an isotonic fluid from the body, there is only one way, that is you are losing blood that is an isotonic fluid in your body, which means you are dealing with a hemorrhage, maybe trauma, maybe surgery. Hemorrhage, very, very important cause of a hypovolemic normonatremia. Clear? Or you can get an adult secretory diarrhea. Adult secretory diarrhea. So where again you can use lose a isotonic solution, because in adult secretory diarrhea, active secretion of sodium will be there and chloride will be there. Along with that, water also will be secreted, because sodium pulls water out along with it. So best example will be cholera. Cholera, isn't it? Best example, where you'll have a hypovolemic normonatremia only. Cholera, they are going to activate the, B subunit of the cholera toxin is going to activate the CFTR gene. When they activate the CFTR protein through cyclic AMP, CFTR will produce chloride efflux, sodium also goes along with the chloride, sodium chloride will go out, along with that water also will go, you will result in diarrhea. That's secretory diarrhea. Okay. Now, second condition, I can tell another isotonic disorder where total body sodium is high, along with the total body water is also high. which means you can see here both are increasing proportionately. So serum sodium will be maintained in the normal range only. What I'm trying to tell is total body sodium will be high here, so the patient will definitely be hypervolemic, no doubt. The serum sodium is the normal range because both are increasing proportionately. So this is what we refer to as hypervolemic normonatremia. What are the examples of hypervolemic normonatremia? Which means the body is getting more isotonic fluid, which means excessive infusions of isotonic fluids like ringed lactate or 0.9% NaCl. 0.9% NaCl and ringed lactate are classic examples of isotonic solutions. Whenever infuse a lot of isotonic solutions, they increase both sodium and water in an isotonic fashion. Nothing will increase in a disproportionate way. Both are going to increase in a proportionate way. That's why they are going to produce hypervolemic normonatremia. So remember, if you are going to infuse 1 liter to me in my body, I'm not going to face any much problem because my kidneys and heart is working normally. So 1 liter is not a big deal for me. But on the other hand, if you infuse 1 liter to the same cardiac failure, renal failure patient, they're going to go for volume overload because they cannot handle that 1 liter. So it is like a volume overload for them, and it's an isotonic volume overload. So they will result in hypervolemic normonatremia only. For that matters, it all depends again. For me, 1 liter is fine. If you infuse 20 liters in 2 hours for me, even I will go for pulmonary edema and dyspnea and death. So my organs cannot handle 20 liters in 2 hours. So it all depends on the handling capacity. Even a normal person, it's not like they can handle 20-30 liters in 1 hour or 2 hours. Similarly, a renal failure, cardiac failure patient is not able to handle even 1 liter in 2-3 hours. So they will go for failure. So it all is relativistic again. So depending on how much your organs are functioning properly. So isotonic fluid in excessive infusion, depending relatively again, what is excessive depends on whether the organs are working normally or not. So that might result in a volume overload state, that is hypervolemic normonatremia. And remember, most of the early stages of renal failure, congestive cardiac failure, liver failure, that is cirrhosis, and even nephrotic syndrome, all these things will have hypervolemic normonatremia only, especially in the early stages, because when they fail, renal failure, it's due to low GFR, and this is due to RAS activation, isn't it? All these things are going to cause sodium overload, but usually it will be proportionate rise only. So they will have hypervolemic normonatremia. Sodium will be normal, but they will be hypervolemic state. So early stage usually will encounter these kind of electrolyte problems only. There will be no electrolyte problems. In fact, there will be hypervolemia, that's all. Clear? So remember, whenever sodium is very high in the body, there is one simple assumption is there. Whenever the total body sodium is high, one simple assumption is whatever sodium you are taking in is not going out of the body. That's why your total body sodium is high. Again, it is relativistic. Even if I take 30-40 grams of salt today, all is going to be excreted in the kidney because I have a good kidney. A patient with a kidney failure or cardiac failure may not tolerate 30-40 grams of salt per day. Even in fact, it's going to kill them because of producing severe volume overload. So it all again is relativistic, which means what I'm trying to tell is whenever you have a total body sodium in excess, it always means that you are taking salt more than what your system could eliminate. Whenever you have a low total body sodium, it means you are taking salt less than what the system is excreting or what the system is losing from the body. The loss of the salt is more than what you are taking. That is what is called as low total body sodium. And the gain of salt or the intake of salt is more than what your system is losing. That's what you result in a total body sodium excess. That's what is going to result in a hypervolemic state. Super. So whenever the the system excreting the salt is equal to the intake of the salt, you will result in a euvolemic state only. This is a very, very crucial point to know. Intake equal to loss, euvolemic state. Intake of salt more than what the system could excrete or lose, hypervolemic state. Intake of salt less than what the system is losing, that is hypovolemic state. Clear? That is also one important principle why in a hypervolemic state you should never give excessive fluids unnecessarily or excessive salt. That's the reason why in these circumstances one of the important aspects of treatment is salt restriction, because your system is losing lesser salt than what you're taking inside. So that's why you advise the patient to do salt restriction. Clear? So then we'll move on to the hypotonic disorder. So what are the examples of hypotonic disorders? Hypertonic disorders means obviously your serum sodium is going to low. That's what I'm going to see. We are going to talk about the hyponatremic disorders. That's hypotonic disorders. The first example is, what if the total body sodium loss is too high compared to that of the total body water loss, which means here you can see the sodium loss is too much great compared to that of what the water loss is. So this will result in a serum sodium to definitely fall because you're having numerator decrease more than the denominator decrease. So you know very well, now since the total body sodium is decreasing, the patient will be having hypovolemia, and since the total serum sodium is decreasing, we can call this disorder as hypovolemic hyponatremia. Because hyponatremia, you are calling it as hypotonic disorder. So what are the examples of hypovolemic hyponatremia? Best example is salt losing states, which means you are losing salt predominantly compared to the water. What are the salt losing states? Classical example, primary adrenal insufficiency. We'll discuss in detail about that. That is mineralocorticoid deficiency. Especially glucocorticoid will be there, but most importantly, why you waste the salt is the mineralocorticoid deficiency. That is the reason why you waste the salt. Secondary adrenal insufficiency we'll discuss later on. That is not going to cause salt wasting. In fact, the electrolyte picture will be a little different from primary and secondary adrenal insufficiency. That's why I'm clearly telling it's primary adrenal insufficiency that will cause salt wasting, not the secondary adrenal insufficiency. Next, you can get in another disorder called cerebral salt wasting syndrome. Very, very important concept and crucial concept again. Cerebral salt wasting syndrome. Salt wasting. A lot of examples are there. These are the two classic examples of salt wasting. Clear? Now, you can ask me why the total body sodium loss is more compared to the total body water loss and why this is disproportionate. So this less total body water salt primarily explain one main reason, that is salt losing states, because in salt losing the salt loss will be more than the water loss. So that's one thing that explains you. At the same time, this hypovolemia, there is second explanation for this. This hypovolemia will result in activation of ADH. We saw in the previous video, one of the powerful activators of ADH is hypovolemia. And they will definitely cause excessive water reabsorption through the aquaporin 2. Because of this excessive water reabsorption, they might result in dilution and probably, like a lesser water loss than you expect because of higher ADH and increased water reabsorption. That is the reason why this water loss is not that great, because ADH induced water reabsorption. So not that much equivalent compared to that of the sodium. This is a very crucial concept to understand once again, because you are going to treat this hypovolemic patients with 0.9% NaCl. That is normal saline most of the time. And we replace, what you do is, the first thing you are going to abolish is the hypovolemia. Hypovolemic state will be abolished, which means the signal for ADH is lost, which means the water reabsorption is lost, which means the patient will lose water, and the water excretion will actually increase here. What is the danger if the water excretion increases? If the water excretion increases, the water loss will become more. At the same time, because you are giving volume replacement means it should contain sodium. Then only it can expand the volume. Without sodium, you cannot expand the volume. So you are giving sodium, which means you are actually increasing the total body sodium also, which means now it will be a disproportionate thing, which means sodium is rising, but water is actually getting lost because of loss of ADH mechanism. You will result in rapid increase in sodium. Rapid increase in serum sodium will happen. This is a very, very important problem that you're going to face in a hypovolemic hyponatremia patient when you are especially giving a, 0.9% NaCl. So this might actually increase the risk of osmotic demyelination syndrome. You have to be very, very careful. So the serum sodium can rise more than what you predict, especially in a patient who's having hypovolemia, because of this ADH-related mechanisms. So be very, very careful. So let us take the second condition where total body sodium will be increased, but the total body water is increasing more than the total body sodium. So which means what is going to happen here, the serum sodium in this state will definitely go down, because you can see the denominator is actually increasing more than the numerator. So obviously by principle of math, definitely your serum sodium should decrease. So here you can see the total body sodium is high, which means definitely the patient will be hypervolemic. And since the sodium is low, definitely the patient will be hyponatremic. So this is what we define as hypervolemic hyponatremia. Here actually the problem is the excessive total body water. That's the problem. So why this happens? Let us see. The examples for these conditions are again volume overload states. Lot of volume overload state, but in advanced stages. Volume overload states, especially in advanced stages. In advanced stages, there will be a mismatch. Usually, in early stage, there won't be a mismatch. In advanced stage, there will be a mismatch between sodium and water, resulting in a dilution. So you can get in renal failure, you can get in CHF, you can get in cirrhosis, you can even get in nephrotic syndrome. In fact, if they ask you the most common electrolyte disturbance in a nephrotic syndrome, answer is hypervolemic hyponatremia. Hyponatremia is the most common electrolyte disturbance in nephrotic syndrome. I mean, don't tell in renal failure. Renal failure, the most common electrolyte disturbance is hyperkalemia. That's different. But in nephrotic syndrome, the most common electrolyte disturbance is hyponatremia only. That's due to dilutional hyponatremia. Be very clear. Okay. So in advanced age, especially in these two disorders, whenever you have hyponatremia, it indicates very, very advanced age, which means it indicates a poor prognosis. Presence of hyponatremia in advanced diseases that cause volume overload itself is an indication of bad prognosis, especially in CHF and cirrhosis. Hyponatremia should not be there. It means it's an advanced disease if it's there. So this is what is going to happen. So which means here the hyponatremia is actually due to diluting effect of water. That's why this hypervolemic hyponatremia can also be referred to as something called a dilutional hyponatremia. Because here the water is diluting the whiskey, that is the sodium here. So excessive water, dilution. So it's a dilutional hyponatremia. Okay. So let us come to the next state. Next state, you have total body sodium, where it can be completely normal, perfectly normal, but only the water is increasing. These are pure water excess states. So obviously, here also the denominator is decreasing. So since the denominator is increasing and the numerator is normal, which means here again your sodium has to decrease by principle. Because you are increasing the denominator more and more, keeping the numerator intact. So which means the sodium has to decrease. So again, you will result in hyponatremia only. There is no doubt about that. That's why it's an hypotonic disorder. But since the total body sodium is absolutely normal, you will result in a euvolemic hyponatremia. Simple. You will not get a hypovolemic or hypervolemic hyponatremia. Instead, you will result in a euvolemic hyponatremia. You can ask me where this excess water goes then. That's a topic of a next video. So we'll be discuss where this excess water goes. But right now, understand, it will result only in a euvolemic hyponatremia. But best example comes from a condition called SIAD, that's called syndrome of inappropriate antidiuresis. Even though traditional textbooks give SIAD-H, we don't call SIAD-H because it's not syndrome of inappropriate ADH action, it's due to syndrome of inappropriate antidiuresis. So as a beginner, it's okay to know that it's high ADH, but it's not always due to high ADH. It might be due to a lot of other problems that mimic high ADH. That's why we simply call it a syndrome of inappropriate antidiuresis. That's all. So what happens is it's like over antidiuresis, which means it's like over ADH action. It's something that simulates excessive ADH, or ADH itself is in excess, causing excessive antidiuresis, which means excessive water reabsorption. So you know what is the ADH action? If you take the kidney, the ADH action is to cause more and more water reabsorption. If there is excessive antidiuresis, similar to how ADH acts, obviously water is going to increase in the blood, which means the serum osmolality is going to drop, which means blood is going to get dilute blood. Whereas urine will get concentrated. Urinary concentration will increase, which means my urinary osmolarity is going to increase for that matters. So here you can see it's a pure water state. Whenever you call the term antidiuresis an ADH related principle, it's a pure water condition. You don't have any problem with the sodium. So that's why you raise only water here and you result in a euvolemic hyponatremia. The next condition I can discuss is on primary polydipsia, or otherwise called as functional or psychogenic polydipsia, where here the patient's fantasy is only drinking water. Drinking water. That's his only fantasy. He keeps drinking these hypotonic fluids. See, when you drink isotonic fluids, that's different. Here the patient keeps drinking only hypotonic solutions like water. Water is actually having lesser osmolality compared to that of what you see in the blood. So water is definitely hypotonic compared to that of the plasma or blood. So you're again drinking hypotonic solution, which means you're diluting the blood by drinking excessive water. So you might result in a euvolemic hyponatremia. But remember, completely it's a different entity. SIADH will not present like, even though you have telling two conditions, but it's totally different. Primary polydipsia will have polyuria and polydipsia. SADH will never have a polyuria and polydipsia. So completely different entities, but still they can produce similar condition called euvolemic hyponatremia. You have to be clear about that. So these are some of the examples of hypotonic states. Now let us move on to the hypertonic states. What are the examples of hypertonic states? Which means I'm going to deal with hypernatremic conditions, hypernatremic states. So number one, let me tell there is total body sodium and total body water. I'm telling that the total body sodium increase is more than the total body water increase. So simple condition number one. So obviously here, because of the imbalance, the serum sodium will increase because the numerator is here increasing more than the denominator. So definitely the serum sodium will increase in this matter. So which means patient will have hypernatremia, no doubt about that. But since total body sodium is high as well, they will result in hypervolemic hypernatremia. Where you are going to get hypervolemic hypernatremia. Hypervolemic hypernatremia is quite rare, theoretical reasons. In theory, you can get this hypervolemic hypernatremia by salt water ingestion. Salt water excess usually happens in seawater drowning sometimes, but not a common condition. Theoretically, again, you can result in excessive infusion of hypertonic fluids like 3% NaCl. Excessive 3% NaCl infusions, again, it's iatrogenic, but we give it in very controlled settings in ICU. 3% NaCl we give in excess and induce hypernatremia and hypertonicity to treat conditions like raised ICP and cerebral edema. So it's something controlled, very rare, again to call it as a disorder. But in practically, so what is the most common condition where you encounter this? Usually, whenever a patient with a hypervolemic normonatremic patient, let us assume a patient is having hypervolemic normonatremia, which means some patient is having volume overload state. Volume overload state due to renal failure or CHF or cirrhosis, they are getting sick. For example, let us assume they are getting fever. And because of fever, they are getting altered mental status. And there is nobody to take care. Poor home care is there. Because of that, their water intake will decrease. Decreased water intake. Because they have reduced water intake. And remember, what will be the initial picture or equation of a hypervolemic normonatremia? So total body sodium will be increased, whereas total body water will also increase. Because of that, the serum sodium will be maintained in the normal range, which means both are in the proportionate range. That's why serum sodium is normal. So now this patient is getting fever, sick, altered mental status, and there is no proper care for this patient, means slowly they are going to go for hypodipsia or adipsia, which means water intake will reduce because they don't drink. At the same time, a patient who is having fever will have excessive insensible water loss. They're going to lose water more and more through the body itself, body heat itself. So what will happen is this total body water will diminish and the total body water will start decreasing actually. But this sodium has nowhere to go out of the body unless until you give a diuretic. So they don't take the tablets also. So total body sodium will be high, but total body water will start shrinking step by step and they will result in hypernatremia because numerator is increasing, denominator is decreasing, hypernatremia. So which means they will go for hypervolemic hypernatremia. This is the commonest scenario where you encounter this hypervolemic hypernatremia. Very simple scenario. Patient will be a cardiac failure patient and she will get suddenly UT and urosepsis, go for delirium, altered sensorium, and the kids, sons and daughters will be in US. They won't even call once or twice a day to the mother to see how she is. And maid will be on leave, typical scenario, and maid will not look after properly and they will be brought after 2 or 3 days in altered mental state. If you see sodium will be 150 or 160. Very simple, because of poor water intake. Clear, water is shrinking, but sodium is not shrinking. Patient might look hypervolemic, but actually patient will be hypernatremic. So very simple scenario. Clear? Second example, let me tell total body sodium is decreasing, but total body water decrease is more compared to the total body sodium decrease, which means in this condition, relativistically, if you see total body sodium is decreasing, but water decrease is more, which means patient sodium will increase. Obviously, this patient will be hypovolemic, no doubt. At the same time, they will be hypernatremic. hypernatremic also. So this is what we call it as hypovolemic hypernatremia. The classic example where you get a hypovolemic hypernatremia, where there is mismatch will be there, is when the patient is having a vomiting. Clear? When the patient is having a vomiting. Classic example, vomiting. Why in vomiting? Because vomitus contains actually more sodium compared to that of what you lose in the diarrhea. Point number one. At the same time, a vomiting patient will not take sufficient water. Again, there is reduced water intake in these patients. That's why I'm telling you. Hypernatremia is usually due to hypodipsia or adipsia. Dipsia means taking water. Hypo means lower intake of water. Usually hypernatremia will be due to low water intake. Hyponatremia will be due to excessive water in the body due to some reason, either relatively excessive water, what you need more than that you're taking, or actual excess of water, like primary polydipsia. That's what hyponatremia is all about. Hyper is all about hypodipsia or adipsia. You don't take sufficient water, that's the problem. Vomiting is classic example where you lose sodium through the vomitus, but you don't take sufficient water because you're vomiting. That's why water loss is more compared to the sodium loss. Hypernatremia. You can get in osmotic diarrheas, means in laxative abuse and laxatives also you can get this hypovolemic hypernatremia. That is also one reason. Osmotic diarrhea means there are osmolar content in the body. I mean in the lumen, intestinal lumen, you have some osmolar content that is actually pulling water only predominantly compared to the other sodium. Because of excessive stool motion, sodium also will be lost, but water loss, pulling of water by this osmotic substance is actually more compared to that of sodium loss. So that's why you are going to result in hypovolemic hypernatremia. And rarely you might, there is another condition where you will get a relative hypernatremia. Relative hypernatremia, patient will be hypovolemic as well. This is not a true hypernatremia. I'll tell you why. So you might get in conditions when you are using osmotic substances. Osmotically active substances in the blood. When there is osmotically active substance present in the blood, you might result in a relative hypernatremic state. Why? Because let us assume what are the osmotically active substances like mannitol, glucose, mannitol, all these things. For example, let us assume an example of a glucose or a mannitol. I told you glucose, especially in the absence of insulin, will stay in the ECF only, will not enter the ICF. And mannitol, obviously mannitol is an ECF substance, it never enters the ICF. So glucose and mannitol in fact is in the intravascular compartment only, it will not go even into the interstitial fluid also. So mannitol and glucose, what they are going to do is, you have the cells here, they are going to pull a lot of water from the ICF compartment. ICF compartment, they are going to pull a lot of water. So there will be so much of water that is pulled into the intravascular compartment, and that will be eliminated because mannitol and glucose both are going to get eliminated in the urine. So once they go in the urine, so they don't only go alone, they are also going to cause excessive water loss. Excessive water loss. So which means if you take the equation, the total body sodium will decrease only very little because of excessive movement of urine. Some sodium will be washed out excess, but the most important thing is the water is also lost in too much excess. So obviously actually you are resulting in a hypernatremic state in the body. It's like a relative hypernatremia. Why I told the term relative hypernatremia is the reason because, but if you take the blood and see, suppose if you take this blood column, and examine under the your serum sodium assessing machines, they will actually show hyponatremia. Actually, they will show hyponatremia. It's actually like a false hyponatremia. It's not a true hyponatremia. Let me explain you in hyponatremia section. It's a false hyponatremia. Why? Because this movement of water from the ICF into the intravascular compartment will transiently expand the intracellular compartment and they will cause a transient dilutional effect. This is due to transient dilutional effect caused by these osmolar substances. Because the transient dilutional effect in the intravascular compartment caused by these osmolar substances, because the dilution of the sodium in that particular area of the vessel transiently, if you take the blood, you will result in hyponatremic picture only. But you have to understand that this water that is pulled from the ICF is going to actually go out of the body only, and they are going to produce a relatively hypernatremic state over time, which means patient is like having a relatively hypernatremic state. That is why whenever you have an excess glucose, correct, excessive glucose. For example, take a condition like hyperosmolar hyperglycemic state, previously called as HONC or DKA. Patient will be terribly dehydrated because they are losing excessive water. Terribly dehydrated patient, but actually the blood may show hyponatremia. So that is why in both these conditions, see whether the patient initial resuscitation, patient usually will be in shock and hypotension. So initial resuscitation, obviously whenever they are in shock and hypotension, it means patient is having hypovolemia. So the resuscitation fluid of choice is NS. So once the shock resolves and initial resuscitation phase is over, you shift the fluid back, especially if the CBG becomes less than 250. 200 by some like local guidelines, but 250 is the universal guideline. Once the capillary blood glucose becomes less than 250, the osmotic pulling of the water by this glucose will be reduced, and the patient will no longer exhibit hyponatremic principle, because once the water doesn't come, because the glucose is lowered, your intracellular compartment, the transient expansion of intracellular compartment will not be there anymore. So now the patients will start manifesting this hypernatremia. So that is why once the CBG becomes less than 250, you actually shift to this is an isotonic solution. Actually, you have to shift to a hypotonic solution like dextrose 5 water or half normal saline. You shift to a hypotonic solution. Half normal saline means 0.45% normal saline. Why? Because you are actually dealing with a hypernatremic state, not a hyponatremic state. Initially, they might look hyponatremic because that's a false hyponatremia. So shock, you resuscitate with NS, universal fluid of choice. But once the shock resolves and CBG becomes less than 250, the pulling of water from the ICF reduces. The transient expansion of intravascular volume is no longer happening. That is no longer causing a dilutional effect. And now the hypernatremic picture start coming up. That's why to avoid that, to hypertonic state and causing more and more problems, you are actually giving a hypotonic solution to neutralize the hypertonic state. That is the reason why when the CBG becomes less than 250, you shift to a hypertonic solution like half normal saline or dextrose 5 water. In hyperglycemic states, usually we prefer a half normal saline. Simple, isn't it? These are very beautiful concepts to understand. So this is what we call as the relative hyponatremia, because the patient will have a false hyponatremia. That's the reason. So these are the conditions where you're going to result in a hypovolemic hypernatremic states. Then you can get something called a euvolemic hypernatremia also. So let us see the total body sodium and the total body water. Let us see the total body sodium is normal and only the total body water is shrinking, which means obviously the serum sodium is going to increase because the denominator is only decreasing, numerator is the same, which means serum sodium will definitely increase. So since the total body sodium is normal, patient will be definitely euvolemic, there is no doubt about that. But since the total body water is shrinking, patient will be hypernatremic. What are the reasons for this? Here again you can see the patient is not taking sufficient water. Again, hypodipsia is the primary problem here. So the best examples will be fever. So when you get a fever, you don't replace the loss with sufficient intake. You don't take, like you're sleeping, not taking care of yourself properly, and you're not taking sufficient water. So what will happen in this scenario? There will be excessive insensible water loss. This is the most practical scenario. Excessive insensible water loss will be there and it's not like replaced sufficiently. So there is a relative hypodipsia or adipsia in the patient. So because of that, you will result in this euvolemic hypernatremia. Fever is a classic example. Second example you can call it diabetes insipidus. In diabetes insipidus, there is central nephrogenic. Either there is a low ADH circulating in the blood, or ADH is good but it's not acting, called a nephrogenic diabetes insipidus. So whatever may be the case, there is low ADH action on the kidneys. Because of that, you will result in water loss, because ADH is an anti-diuretic hormone. They reabsorb water. So there will be more free water loss, resulting in loss of water from the body, causing hypernatremia. But please do understand, even in diabetes insipidus, patient will not be hypernatremic unless and until they get sick and they don't take sufficient water. Because you know very well, this even in diabetes insipidus patient, the serum sodium tends to become high and serum osmolality tends to become high. This will definitely activate the thirst mechanism very, very badly. And this thirst is something very annoying, like this high serum osmolality will not let you be peaceful at all. This is very, very annoying. Like they will be very thirsty. And this thirst means they are going to drink a lot of water. And why they drink a lot of water? To neutralize the serum osmolality and this excessive serum sodium. So which means even in diabetes insipidus patients, they will not have this hyperosmolar state when you take the blood actually, because just 5 minutes back they would have taken 1 liter of water to neutralize that serum osmolality. So excessive intake, is actually to neutralize that serum osmolality and serum sodium. That is in excess. Usually don't encounter hypernatremic even in a diabetic insipidus patient unless and until the patient doesn't take sufficient water. That's why a diabetic insipidus patient gets sick. Or if the patient doesn't take sufficient water, you get that hyperosmolality and hypernatremia. Not in usual patients that you see in the OPD, because they will counteract by taking sufficient water. That is why diabetic insipidus is sometimes difficult to diagnose. That's why you give a test called fluid or water restriction test. Why you do water restriction test? Because you stop the patient from taking water, then only this hyperosmolarity and hypernatremia will start surfacing and start manifesting. That's why that's a gold standard test, water restriction test, Miller-Moses test. Clear? So these are some classic examples of a euvolemic hypernatremia. Clear? So now, this is a very simple understanding you are knowing. So now you know what you mean by a hypovolemic normonatremia, hypervolemic normonatremia, hypovolemic hyponatremia, euvolemic hyponatremia, hypervolemic hyponatremia, hypovolemic hypernatremia, euvolemic hypernatremia, and hypervolemic hypernatremia. All these states, you know how it happens and what are the basic principles in a simplified equation, and what are some important examples for these disorders. And final take-home point and the final nutshell is the fact that whenever you are encountering a hypotonic disorder or whenever you are encountering a hyponatremia, you have to understand the fact that here the problem is water excess. Usually majority of the hyponatremic problems are due to water excess. Similarly, majority of the hypernatremic disorders, hypernatremia or hypertonic disorders, are due to hypodipsia or adipsia, which means poor water intake. Hypodipsia or adipsia. Majority of the disorders, not all the disorders, majority of the disorders are due to this only. Where you can clearly see most of the sodium problems are actually water problems. They are not really sodium problems, they are actually water problems in the body. So correct the water properly. So that's the idea. And I didn't tell you, if they ask you about dilutional hyponatremia, I already told you this hypervolemic hyponatremia is a form of dilutional hyponatremia. Similarly, this euvolemic hyponatremia is also a form of dilutional hyponatremia only. Here again, the problem is the excessive water that is diluting the whiskey, that is sodium here, so causing hyponatremia. So whenever they ask you dilutional hyponatremia, it is hypervolemic as well as euvolemic hyponatremia. Both are going to behave like a common terminology called dilutional hyponatremia. And next important thing a student keeps on asking me every time is that, sir, how to find out this total body sodium? You need not find out the total body sodium. Why? Because I told you by simple logic here, the total body sodium is the one that determines the volume status, isn't it? Total body sodium is the one that determines the volume status. I told you. That's true. I'm not denying the fact. But total body sodium and the volume status are synonymous with each other, which means I'm not attempting to find out the total body sodium at all. Actually, find out the volume status clinically. So I'm going to do a clinical examination and find out the volume status clinically, and you can determine the total body sodium. And predict, and not determine, predict the total body sodium. If I'm seeing a hypovolemic patient, I assume the total body sodium is low. If I encounter a hypervolemic patient, I'm assuming the total body sodium must be high. I'm encountering a euvolemic patient, I can tell the total body sodium must be normal. On the other hand, even in a very clinical way, if you want to tell, I'm seeing a hypovolemic patient, I can tell I have to give more salt because the patient is actually having less salt intake compared to the loss in the system. If I see a hypervolemic patient, I can assume that the patient is having comparatively more salt intake than what the system is losing, and I should give a salt restriction to this patient. If I'm seeing a euvolemic patient, the salt intake is equal to salt loss, so I can manipulate by either giving excess salt or low salt, doesn't matter here, because the patient's salt intake is matching the salt loss. Simple. It's all clinical. You're not going to find out the total body sodium at all, so don't ask that question again. So finally, we have to close the chapter after discussing on what are the different types of fluids that you're going to encounter in your practice. So there are three types of fluids, these are called as hypotonic fluids. And second one, we have isotonic fluids. And third one, you have hypertonic fluids. Hypertonic fluids. So what are the nature of the isotonic fluid? Isotonic fluids are called isotonic because their tonicity or osmolarity is equal to that of the plasma osmolarity. That's why, or serum osmolarity. Hypertonic fluid means they are less in concentration compared to the plasma, which means they are going to have lesser osmolarity than that of the plasma. Whereas hypertonic fluids, they are going to have more plasma osmolarity, more osmolarity than compared to the plasma. That's why they are hypertonic solutions. Clear? Will they cause fluid shift? Definitely no fluid shift in case of isotonic solutions because they maintain the plasma osmolarity, because they are equal. Adding more and more whiskey of the same concentration is not going to cause any change in the concentration. So it's like no change in the plasma osmolarity. And they're not going to produce any problem. So remember, here they are going to reduce the plasma osmolarity because by giving this fluid, even because they are less than the plasma osmolarity, when you add them, they will make the plasma more and more dilute and they're going to produce reduced plasma osmolarity, which means they will produce fluid shift. Yes, they are going to produce fluid shift. And what will be the fluid shift? If they reduce the plasma osmolarity, which means it's like reducing the serum osmolarity, means the fluid will shift from low osmolar region to high osmolar region, that is ECF towards ICF. So fluid shift will happen from ECF to ICF. Hypertonic solutions will increase the plasma osmolarity, obviously, because they are hypertonic to that of the plasma. So obviously there will be a fluid shift. Yes, because they are increasing the ECF osmolarity, they will cause a fluid shift from ICF to ECF. The ICF will shrink here. What are the examples of fluids? I can tell any, first let us see the isotonic fluids. First, 0.9% NaCl, that is the normal saline that we use, is isotonic, perfectly isotonic. Ringed lactate is again a good isotonic solution. And dextrose 5 water. And again I can put a star over here because I'm telling condition supply. Dextrose 5 water on paper, it's isotonic only. If you take the osmolarity of dextrose 5 water, which is lying here in the table, and we take the plasma osmolarity, both are going to be the same. On paper is equal to isotonic. But in vivo, inside the body, they are going to behave like a hypotonic solution because it's a dextrose 5 water. They have 5% dextrose. Otherwise referred to as 5% dextrose or 5D. So when you are infusing this 5% dextrose, the glucose or dextrose that is present in the solution will be rapidly metabolized by the RBCs, which are totally dependent on glycolysis, and they take up a lot of glucose and leaving only the free water behind. So which means adding just free water is like hypotonic only. In vivo, they are behaving like hypotonic only, but on paper they are isotonic solutions. Clear? So very important again. So that's why, you will, whenever you get an ad, you will know that mutual fund investments are subjected to market risk, and please read the offer documents carefully before investing. Like that condition supply, dextrose 5 water is a hypotonic solution. That is what we use for. So anything less than 0.9% NaCl is going to be hypotonic solution, like 0.45% NaCl, 0.3% NaCl, 0.6% NaCl, doesn't matter, they will be hypotonic. Half normal saline, quarter normal saline, 1/3 normal saline, 2/3 normal saline, all these are hypotonic solutions. Anything less than dextrose 5 water, like 2.5% dextrose, 1% dextrose, definitely they will be hypotonic solutions, even on paper. So next, what are hypertonic solutions? Anything more than 0.9% NaCl, the best example here is hypertonic saline, that is 3% NaCl. Or you have 5% also, you have 10%, 30% NaCl is also there. Varying purpose either, but very commonly what we use is 3% NaCl, hypertonic solution. Then anything more than dextrose 5 water, like 20% dextrose, 10% dextrose, 5% dextrose, 50% dextrose, all these things are hypertonic solutions. Then you have dextrose normal saline, DNS, again star condition supply. Again on paper, this is hypertonic solution, because they are containing two things. One is 5% dextrose as well as 0.9% normal saline. But in vivo, they act as isotonic solutions. But they are isotonic in vivo. which means the dextrose, again 5% dextrose will be rapidly metabolized, leaving only the 0.9% normal saline. So on paper it is hypertonic, but in vivo it is a isotonic solution. But remember, whenever they ask an exam, you have to tell what is on paper only. What is on paper only you have to tell. DNS is hypertonic and dextrose 5 water is isotonic. That's what you have to answer in exams. But actually what we intend to use for is something different. D5 we use for hypotonic purpose to induce hypotonicity, and DNS we give as a isotonic solution as a practice. Okay, what are the uses of these solutions? Uses, isotonic, very simple. The best use of isotonic solution will be in shock states. Especially NS is the preferred fluid and crystalloid for shock. And second, where I'm going to do is when you need isotonic volume replacement. Isotonic volume replacement. When you need an isotonic volume replacement, especially when the patient is actually having hemorrhage, where you have isotonic volume replacement will be there. So sodium will not change, no fluid shift will happen. So definitely you are going to treat with the normal saline or ringed lactate. D5 we don't use because technically D5 is a hypertonic solution. NS and RL is what we prefer. In that NS is the best choice. Then even for vomiting, I feel NS is the best choice. For diarrhea, RL is the best choice. You can write even like this. Vomiting, we prefer NS, and for diarrhea, we prefer RL. But this is only for theory, and for all shock states, hypoperfusion states, we use NS as a best therapy. I'll let you know in nephrology why NS and RL are used in vomiting and diarrhea respectively. A lot of reasons are there. But again, this is only for theory. For practicality, resuscitation fluid of choice is always normal saline, more than ringed lactate. In shock states, you can see ringed lactate, according to many theories and many papers, is actually having high risk of renal failure compared to NS. That's why still many guidelines are telling NS as the best crystalloid in shock states. Still the debate is ongoing. So be very careful about that as well. When you're going to use hypotonic solutions used in hypertonic states, obviously. In hypertonic states, you have to bring back the tonicity of the plasma to isotonic level. So you use hypotonic solutions here. So how can you use this? In what purposes? Hypertonic means especially in hypernatremia. In hypernatremic states you can use. Either you can get absolute hypernatremia or even in a relative hypernatremia. Relative hypernatremia means when the patient is having excessive glucose in the blood. We discussed this phenomenon already. Excessive glucose in the blood. In very hyperglycemic states like glucose in the range of 600, 700, patient will be having severely hypertonic plasma. At the same time, patient will be having relative hypernatremia also. So these conditions can be treated with hypotonic solutions like dextrose 5 water or half normal saline. We discussed that already. Best example for this state is DKN, hyperosmolar hyperglycemic state. The most important is the HHS, where you'll have severe elevation of glucose, like even 1500 milligrams per deciliter of blood glucose I have seen. And highest record is almost 2840 in history, but what I have seen is around 1500 milligrams per deciliter of glucose in HHS. That's the highest, I have seen, but you can encounter any amount of blood glucose, very, very high level blood glucose in HHS. The basic and mechanisms we'll see in the pancreas chapter. Then, when you will use hypertonic solutions, use of hypertonic solutions is very simple. Again, you are going to use in life-threatening situations usually. What are life-threatening situations? Life-threatening hypotonic states, you can use hypertonic solutions like life-threatening hyponatremia with severe symptoms, symptomatic hyponatremia, where classically we use 3% NaCl, especially when the patient is having coma, seizure, in all these conditions. Second, life-threatening hypoglycemic states. In life-threatening hypoglycemic states, like patient is again having a coma, seizure in life-threatening hypoglycemia, they come with paralysis and all. So in those conditions, you urgently give 25% or 50% dextrose, isn't it? These are some of the examples where you use a hypertonic solution. And similarly, you can use in raised ICP patients where you're going to actually prefer a 3% NaCl, for example. So in raised ICP, again, because of the fluid shift, because in raised ICP, since hypertonic solutions cause the fluid shift from ICF to ECF, it's actually beneficial, especially in what type of cerebral edema? We know it's a cytotoxic cerebral edemas. Like classic example is stroke, ischemic stroke. In those conditions, you can use this 3% NaCl as a good drug. Now, treatment. So what is the treatment you are going to give? treatment we know, uses we saw, and what are the cautions you have to take, precautions or contraindications. Remember, isotonic fluids, only one problem is there, they can cause volume overload. Beware of volume overload state, because they produce sodium and you are giving large quantities of isotonic solution, means there is a problem of volume overload, so beware of the volume overload state, especially the patient is having some organ failure like cardiac failure or renal failure. They can go for pulmonary edema and die. And what about this hypertonic solutions? Hypertonic solutions are contraindicated in shock states. Number one, you have to be very, very sure they cannot be given in shock states. Actually, they might cause a lot of problems. And second, whenever the patient is having raised ICP, they are contraindicated. Absolute. It's not a, I mean, it's a joke actually, isn't it? This causes fluid shift from ECF to ICF, which means how can you give in raised ICP? You know, like they're going to cause more cerebral edema and the patient will definitely die. You cannot give hypertonic states in raised ICP. And next, hypertonic solutions. The most important caution that you have to take is, again, this contain a lot of sodium, but this will not be given in high volumes. That's one problem. I mean, good thing. So volume overload is actually quite rare compared to what you get in isotonic solutions. You might think the sodium is in excess here, so you might get more volume overload. But actually no, because they will not produce that much volume overload because you are giving in lesser quantities actually. Hypertonic solutions. Actually, you will use in raised ICP only in emergency states. That's the reason. But still, volume overload is a problem here and you have to be cautious of this side effect. And next, hypertonic solutions has to be very cautiously used because they are very powerful vesicants. Because they are very powerful vesicants, this agent should be very cautiously used because they can produce severe thrombophlebitis. They can produce severe thrombophlebitis. That is the reason a single shot of hypertonic solution, like you are giving 50D just to make the patient wake up, fine, you can use in the peripheral line, or a bolus of 3% NaCl where you are going to use in a life-threatening hyponatremia, fine. But you are giving continuous infusions, for example, maintenance 25D or 10D for hypoglycemia, or maintenance 3% NaCl in a patient with raised ICP. These things where you have to give continuous infusions of these drugs, it's better to prefer a central line because they are very powerful vesicants and they can produce severe thrombophlebitis. Next thing, what you have to know is these drugs, when they extravasate, can cause severe tissue injury because they are very powerful vesicants again. If they extravasate, they produce severe tissue injury and even they can produce tissue necrosis as well. Be very careful about this side effect as well. So you have to be cautious about this problems you are encountering. I think we have discussed a lot in the basics of sodium and water balance. I have tried to tell almost everything that you need to know because this forms the core crux and the basics of what you're going to understand in the future in the next few videos. So please go through this video very carefully, and I think it makes very clear and I substantially explained each and everything to understand. So with this, we'll close this video and we'll move on to the next section on hyponatremia.